Hello, everyone. Welcome to our session today titled Taking Aim at the TYK2 Pathway in Psoriasis, Addressing Unmet Treatment and Patient Needs with an Innovative Therapeutic Approach, put together by PeerView Live. And tonight's speakers are Dr. Ken Gordon, whom I will introduce in more detail a little bit later on in the program, and myself. I am Professor of Dermatology and Associate Dean for Clinical Research at the University of Southern California. And I want to also take the opportunity to thank Medical Learning Institute and PeerView for providing this session, as well as Bristol Myers Squibb for providing the educational grant for this webcast. Please look out for poll questions that we'll be posting during the session, and please feel free to ask questions to our faculty by entering them in the space that is provided. Here are our disclosures. And here's the planning committee and content peer reviewers. And you can also go to peerview.com/psoriasis21 to download the slides and the practice aids. And then you can apply for CME credit by clicking the buttons located in the left-hand panel. And if you have any more questions, feel free to send an email to live@peerview.com. And please join the conversation too on Twitter. And now I have the pleasure of introducing Dr. Kenneth Gordon, who is professor in Thomas J. Russell Family Milwaukee Community Dermatologist Chair in the Department of Dermatology at the Medical College of Wisconsin in Milwaukee. I am very excited today to share this podium virtually with him and with you to discuss this important topic. And I just want to say that Dr. Gordon is the leading expert in psoriasis, and I'm just very excited that you get the opportunity to hear him today on the topic of disease burden and unmet treatment needs in psoriasis.
Well, thank you very much, Dr. Armstrong, and it's an honor to share a podium with the person who really is the person who's really leading psoriasis information these days. So really appreciate it, and I like to thank PeerView for giving me the opportunity to speak today. So we think about psoriasis, and in a clinical sense, we always look at psoriasis, which is a diagnosis that we all can make from across the room. We oftentimes forget, and we always have to keep in mind that there's a patient attached to that, the skin disease, and that the things that's really driving most of the patients to see us are the signs and symptoms of psoriasis. So psoriasis, as we all know, is an immune-mediated disease. Lots of folks involved, about 8 million Americans, which is a very significant public health issue. And while we oftentimes see the well-demarcated red scaly plaques of psoriasis, we need to think that the individual needs and their perception of psoriasis is what's really driving us to treat them, and that we have to take that into account as we go about thinking about therapy for that patient. We've all read about the different subtypes of psoriasis, and most of the time we think about chronic plaque psoriasis, which are those well-demarcated red scaly plaques. But there are other variations as well, guttate psoriasis and what I like to call guttate syndrome, which are the explosive small little plaques that we see oftentimes following an infection. Pustular psoriasis, both the localized and the disseminated pustular psoriasis that we can see, where patients begin to get quite ill from their disease. And the most severe case, erythrodermic psoriasis, we're discovering greater than 80% of the body's surface area. All of these things we have to think about when choosing therapy, because these different variations of psoriasis do have different ways we would go about treating them. And then we also have to think about special sites. The most common one we think oftentimes see is inverse psoriasis. That is in areas like the axillae or the groin area. And it looks a little different, maybe not as much scale, a little bit not as sharply demarcated and a little shiny. But it's very important in a patient with psoriasis to be able to distinguish that from other possible etiologies of having intertriginous disease. And it's one of those things that I see very, very frequently when a patient is referred for a fungal infection of the groin or the axillae from a primary care provider. We always have to think about inverse psoriasis. Nail psoriasis, another very common problem, oftentimes something that bothers the patient much more than we think and we can imagine. Pitting is the thing that we think of with psoriasis most frequently, caused by psoriasis in the matrix of the nail. But there are also things that are involved with subungual areas, including onycholysis or lifting of the nail plate, or red spots of psoriasis in the nail underneath the nail plate, which we often call salmon patches. The nail thickening, crusting of the nail, and nail plate crumbling can really show a nail dystrophy that can be quite debilitating for patients both physically and emotionally. Of course, palmar plantar psoriasis is something that we all see frequently and can be extraordinarily debilitating for patients. I always like to think about the patient I once saw early in my career who lost a job because she couldn't shake hands as a rental agent for a major business. And so I think we always have to keep that in mind of the importance of the palms and soles and difficulty walking when we treat patients with psoriasis. Fissures are common and can be very disabling. Nail psoriasis can be common as well involved. And you can also see plaques or you can see pustules. Now, there is some controversy whether palmar-plantar pustular dermatosis is a condition that is associated with psoriasis or is distinct. But any way you look at it, psoriasis of the palms in particular and also the soles can be very, very difficult to treat, painful, and debilitating. Now, classifying psoriasis severity has been a major controversy, and as Dr. Armstrong knows, it's one of those areas that I find to be very difficult and a bit controversial. So, psoriasis is thought of in many cases. You'll see the rules of 0 to 3% or as being mild disease and moderate being 3 to 5% and severe being greater than 10%. All of those things are just an attempt to determine how we can talk about psoriasis and talk about the extent of psoriasis. It is not necessarily the impact the psoriasis is having on the patient. And remember, that's really what's driving our disease plans. How are we going about attacking the disease? It's the impact on the patient. The International Psoriasis Council did a Delphi analysis, and they came up with the following classification, which I think is the best we have to date, though it is imperfect because it doesn't consider patient quality of life nearly enough. But what they have is psoriasis patients should be classified as either candidates for topical therapy or candidates for systemic therapy, and that's really the distinguishing factor. The latter are patients who meet at least one of the following criteria: a body surface area greater than 10%, or disease involving special areas, and finally, failure of topical therapy. In other words, patients might be candidates for systemic therapy with relatively little disease, but having special areas, a significant impact on quality of life, or failure of topical therapy. All of these are reasons to treat patients aggressively to try to eradicate the psoriasis. What are all the impacts that we see in quality of life with psoriasis? And I'm not going to go into detail with all of these elements for patients with psoriasis. However, I think the big picture is that you have problems with both emotional and physical components of day-to-day life. You can have problems with work, problems with being able to function, do your day-to-day activities. And then you can also have the emotional impact on social interactions, the psychological impact, including the self-image, and the family relationships. But very important is we have to keep in mind that all of those are impacted by the signs and symptoms of disease, particularly the symptoms, itch, pain, all of those elements that make a big impact on all the other aspects of the impact of psoriasis need to be considered when thinking about how to treat a patient with psoriasis. Now, psoriasis is one of those diseases that we tell patients we really don't know why it happens to any given individual. Obviously, there's a significant genetic component of psoriasis, with greater than 70 genes having been associated with the disease over time. But that only explains a small portion of what's going on with psoriasis. There are clearly extrinsic risk factors, all those things that can make psoriasis worse, and it can go from anywhere from trauma to medications they may be on, by active infection. Right now, we sometimes will see patients who are getting vaccines or active viral infections who have flares of psoriasis related to the overall systemic immune process that's going on in their system. Additionally, there are elements of the patient that can make psoriasis worse. Obesity is a condition that's a pro-inflammatory state. Mental stress has been associated with psoriasis for many, many years. All these things can make psoriasis exacerbated, aren't the underlying cause, but can bring out disease and make it more severe for patients, which in many cases, for example, with stress, the psoriasis itself can add to that stress as well. One of the main topics of psoriasis research over time has been comorbid disease associated with psoriasis. Now, the most common of these comorbid diseases is psoriatic arthritis, and that's something we always have to consider. Every patient with psoriasis should be asked, do your joints hurt? Do you have morning stiffness in your joints? And that can include both the peripheral joints and the axial skeleton. But despite the association with psoriatic arthritis, it is not the only thing that we have to think about when it comes to thinking about comorbid disease with psoriasis. Recently, cardiovascular disease has become a primary area of interest where people with greater than 10% body surface area of psoriasis might have a increased cardiovascular risk that is significantly greater than smoking, being an active smoker. And psoriasis has now been mentioned in the American Heart Association cholesterol guidelines. It's a very important aspect when we think about cardiovascular disease. The issue that I think is the greatest comorbid disease that we see is mental health issues, particularly depression, that can be associated with psoriasis. But there are many other things that seem to be comorbid with psoriasis, including inflammatory bowel disease, diabetes, other things that are associated with obesity that can be increased in psoriasis, and hepatic disease, all of which are of very significant importance. And we need to think about when we're treating the entire patient when we think about treating psoriasis. So when we start thinking about therapy, we first need to think about pathophysiology. Now, I'm not going to go into great detail into the pathophysiology of psoriasis today, other than to say what we have is a common pathway for pretty much all the types of psoriasis. You have something that sets it off, a danger signal that has the intrinsic immune process to get started, and that activates plasmacytoid dendritic cells that produce things like interleukin 23 that activate local T cells to produce interleukin 17, and that interleukin 17 pathway is really what drives psoriasis. One thing I want to point out is that the role of interleukin 12 and the Th1 pathway is still somewhat controversial when psoriasis. Does it play a major role in increasing psoriasis? Might it even play a role in mitigating psoriasis? We don't absolutely know. What I think is clear that any treatment that would impact both interleukin 17, interleukin 12, and interleukin 23 is primarily working by impacting the interleukin 23 pathway. And I think that's very important for a number of treatments that impact both elements of this pathway. Now, we've spent the last probably 20 years, and the last 20 years of my career, discussing biologic therapies for psoriasis and thinking about how we can specifically attack different ways of this pathway, different elements of this pathway to improve patients' lives with psoriasis. And there are multiple biologic agents available. The anti-TNFs were the earliest that we're using today, blockade of interleukin 17, blockade of interleukin 23, and medication that blocks both interleukin 12 and 23, all of which have been developed for psoriasis, and we've gotten quite effective at treating with biologic therapies. However, they're not perfect. There are a number of things that limit our use of biologics. There are some patients who don't respond, regardless of what biologic we give them. Some patients experience a loss of response during treatment, which is not an uncommon occurrence. Patients can be phobic of needles, so the parenteral administration, either intravenously or primarily subcutaneously, can be very debilitating for patients. There is some immunogenicity. Biologic therapies are proteins. These proteins can cause an immune response to develop, and that can decrease the efficacy of these responses. And as with almost every treatment for psoriasis and in American medicine today, there are obviously treatment-related expenses. Biologic therapies, much to everyone's surprise, are not inexpensive. So one of the things that's really been pushed over the last few years is, can we develop better small molecule drugs for psoriasis? These can be administered orally, or topically, and that's one of the major potential advantages in the future of new small molecules. Unfortunately, our conventional small molecules that we've used for many, many years, including acitretin, cyclosporin, and methotrexate, are associated with long-term adverse events and drug-drug interactions. And thus, that's one of the reasons we haven't been able to push doses to get high-level efficacy for these medications for the treatment of psoriasis. The most recent small molecule apremilast, which is a phosphodiesterase 4 inhibitor, has some efficacy in moderate to severe psoriasis, but it's limited in comparison to some of our other agents. And especially in the initial states of using the medication, it can be poorly tolerated, thus making it more difficult to use. Thus, I think it's pretty clear to most people who treat a lot of patients with psoriasis, we do have an unmet need for novel oral therapies that are both safe and efficacious and easily tolerable for the treatment of psoriasis. So I thank you for your attention. I'd now like to pass the lecture back on to my colleague, Dr. Armstrong, who will talk more about JAK inhibition and the treatment of psoriasis, and a look at the evidence that we have today.
Great, thank you, Dr. Gordon, and thank you for your valuable insights. So when we think about the JAK-STAT signaling pathway, and it is one of the key pathways that we're going to discuss today, is that it is actually quite ubiquitous among the different pathological states. And it is important to note that upon binding of the cytokine to the receptor, what happens is that the JAKs, they can then phosphorylate the receptor, and that creates a docking site for the STAT molecules to bind. The STATs then dock on those sites on the receptor, which then get further phosphorylated by the JAKs, and then the STATs dimerize and then can travel to the nucleus and initiate downstream events such as transcription of pro-inflammatory cytokines. There are various different types of JAKs that are available, and the ones that we are really focusing on are JAK 1, 2, and 3, as well as TYK2. And the JAKs, they pair with one another, and depending on the pairing, as you can see here, they can have a different effects downstream. And when we're thinking about the JAK inhibitors and their development for the treatment of psoriatic disease, this table summarizes the current state. What we see is that, for example, for psoriasis specifically, which is the fourth column, there are actually no oral therapies that are currently under development for psoriasis. We know that tofacitinib, which is a JAK1/3 inhibitor, has already been approved mainly in psoriatic arthritis. And there are studies looking at other JAK inhibitors such as filgotinib and upadacitinib, which are primarily JAK1 inhibitors in phase 3 development for psoriatic arthritis. And perhaps some of the reasons that we are seeing less in terms of JAK1, 2, and 3 inhibition in terms of therapeutic development is due to, number one, the current landscape, and then but also some of the existing box warnings for the approved JAK inhibitors. Now, when we're thinking about JAK inhibitors for the treatment of psoriatic disease, it is important to understand that JAK and JAKs work in pairs, and depending on which JAKs that you are inhibiting, you get differential effects over the course of disease, and then the patients are affected differentially. And selective inhibition is really name of the game here. And it's very important to note that the more specific and selective one can about inhibiting certain JAKs that are implicated in psoriasis, the more likely the targeted actions of such therapeutic agents are going to be. And now this brings me to TYK2 signaling. So I talked earlier about within the JAK family, we have JAK1, JAK2, JAK3, and TYK2, which has its own name. And why TYK2 is important is that TYK2 can bind with JAK1 or TYK2 can bind with JAK2 to create various downstream different effects cellularly. Now, TYK2 mediates the signaling of 3 important molecules, which are listed here. It's IL-12, IL-23, and type 1 interferons. And we know from Dr. Gordon's talk earlier that IL-23 is extremely critical for psoriasis pathogenesis, and we're still learning to this day regarding the role of IL-12 in psoriasis pathogenesis and signaling. And when we're looking at the role of TYK2 in psoriasis, the TYK2 JAK2 pairing, which is shown here, is responsible for the signaling pathway of IL-12 and IL-23. And IL-12, as was mentioned, is essential for the development of Th1 cells and likely play a role in psoriasis pathogenesis. But most importantly, IL-23 controls the expansion and survival of Th17 cells, which are critical for not only the initiation, but also sustainability of the inflammatory feed-forward cycle in psoriasis. And when we're thinking about the other type of pairing, this is the TYK2 plus JAK1 pairing, we are looking at mainly this pairing mediating the signaling of type 1 interferons. And for type 1 interferons, we're talking about interferon alpha as well as interferon beta. So you may remember from medical school that the role of these interferons are important in a variety of different mechanisms. And importantly, they are very important, for example, for defense, for viral defense that our body has. And in terms of their role in psoriasis, they are important with regards to dendritic cell maturation and activation, as well as polarization of Th1 and Th17 cells. So as we can see, TYK2 and JAK1 pair can be important in our natural biologic defense mechanisms, especially antiviral mechanisms. But in addition to that, they are also important and play an important role in terms of the pathologic pathways involved in psoriasis. So why do we want to target TYK2 as a therapeutic target in psoriasis? Well, a lot of the rationale for TYK2 inhibition actually we learned from patients who have a TYK2 loss of function mutation. So what was found was that those who have a TYK2 loss of function mutation had some defects in several of the cytokine signaling pathway. So the loss of mutation could be partial or heterozygous, which is actually most of the patients, or the loss of mutation could be complete. And what was found was that those with inactivating genetic variants of TYK2 were in general protected from a number of immune-mediated diseases. And importantly, what was shown was that they didn't have an increased risk of hospitalization, and also they did not have significantly increased rates of mycobacterial, viral, or fungal infections among those with a mutation in the TYK2. Now, with that being said, TYK2 inhibition seems to be a promising pathway in psoriasis, and inhibiting this pathway has been explored through a number of developments for psoriasis and psoriatic arthritis. As you can see, deucravacitinib, brepocitinib, and PF06826647 are all being investigated for their role in psoriatic diseases. And I did want to mention there are important differences among these molecules, and the main thing being that deucravacitinib binds to a different domain on TYK2 versus brepo and the PF molecule. The deucravacitinib binds to the regulatory domain, whereas the brepocitinib and PF binds to the active site in the catalytic domain. So they bind to different parts of the TYK2 molecule. So here we're looking at some of the in vitro data that shows a differentiated profile of deucravacitinib, which binds to the green regulatory domain. So you see the deucravacitinib binding site. Imagine that small triangle, white triangle is deucravacitinib. It binds to the regulatory domain. And what happens is that when it binds to the regulatory domain, it causes an allosteric change, conformational change in the molecule, in the enzyme itself. And thereby, because of the conformational change, its active domain is no longer available to bind ATP. And this is different from a lot of other molecules that are approved or in development, where they bind to the active site or the orange part, the sort of that almost chewed out part of the orange part of the molecule. And the concern with that is that because that particular site is quite conserved across across the JAKs, that you can get some cross activity in the inhibition of other types of JAKs, and therefore you may experience may see clinically some adverse effects that are unintended. And here we're looking at, for example, the deucravacitinib's affinity for the TYK2 regulatory domain, which is very, very specific, and it has high affinity for, whereas for the other JAKs 1, 2, and 3, it does not. And so here is a closer view at deucravacitinib binding to the regulatory domain and therefore causing a conformational change in the ATP binding site. And also here is the inhibitory concentration for deucravacitinib. And basically what we see here is that it's highly specific with regards to inhibiting IL-23, interferon alpha, IL-12, more so IL-23 and interferon alpha, as you can see from this table, and has very little inhibitory action on EPO here, which is what we want, because we don't want to unintentionally affect other parts of the hematopoietic pathways. Okay, so now we talked about the mechanism of action of TYK2 inhibition with regards to deucravacitinib. What does the clinical data show? So this slide here shows phase 2 data, and the key thing here, when you look at the blue bars, those represent examples of the approved biologics, and then on the right-hand side, we see green bars, which represent our 2 small molecule oral agents and their efficacy, specifically apremilast and deucravacitinib. So the phase 2 data takeaway for deucravacitinib is that it does have efficacy in both bio-naive as well as biologic exposed subjects, and it validated what we talked about earlier with regards to its being on the right path and right target in terms of affecting key pathways that are central to psoriasis pathogenesis. Okay, so when we look at clinical trial data, one of the key pieces of data we look at are the large phase 3 studies. And this is the phase 3 study for deucravacitinib. And here we are looking at 2 large global studies. They are POETIC PSO1 and PSO2 studies. The 2 studies are identically designed from week 0 to 24, and the patients are randomized into getting placebo, deucravacitinib, or apremilast. And the entry criteria for these patients are quite typical of what we see in moderate to severe psoriasis trials. They must have body surface area 10% or greater, for example, as well as deemed by the investigators to have moderate to severe disease severity. Okay, so let's take a look at the primary endpoints from these 2 large studies. If we focus on the left-hand side of the slide, we see that in POETIC PSO1 study, the primary endpoint of PASI 75 here, that is at least 75% improvement from baseline at week 16. So overall, nearly 59% of the patients in the deucravacitinib group achieved PASI 75. That is compared to 35% in the patients that were randomized to apremilast and compared to 12.7% in the placebo group. And if we look at the POETIC PSO2 study, the identically designed study up to week 24, we also see similar results there. And then if we look at the co-primary endpoint, which is the SPGA 0 or 1, so we're looking at clear or almost clear response at week 16, what we see is that on the left-hand side for the PSO1 study, deucravacitinib, 53% of them, almost 54% of them achieve clear or almost clear by week 16, and compared to 32% in the apremilast group and 7.2% in the placebo group. And on the right-hand side for PSO2, the results are similar. Now we know that it has good efficacy with regards to the primary endpoints. What about some of the secondary endpoints? This table shows a number of different secondary endpoints that were studied in the pivotal trials. And what was shown here is that Number one is that there's good maintenance of response over time. So not only, while we only looked at the week 16 data in the previous two slides, here what was shown in the primary, in the secondary endpoints, what was shown is that by week 52, there is good maintenance of response over time. And also, in addition to that, we also see data for hard to target areas such as the scalp, where deucravacitinib also works well. And in addition to a number of different quality of life measures where patients have improved significantly as a result of being treated. So just diving into the scalp data a little bit more, we know that scalp can be one of the hardest areas to treat. Oftentimes it can be the first area of onset for many of my patients, and it can be very difficult to treat for some patients. And here we're looking at the response in terms of scalp PGA of clear or almost clear. And what we see is that by week 16, about 71% of the patients on deucravacitinib group will have achieved clear or almost clear by week 16, compared to 39% of patients in the Prestillous group and 17% in the placebo group. And this was similar in terms of its performance in the PSO2 study. DLQI. So as we know, DLQI, or Dermatology Life Quality Index, is a measure of how skin disease affects patients' quality of life. And DLQI 0 or 1 has been determined to be really meaningful with regards to patients having no negative impact or very little negative impact from their skin disease. So this is a success measure in terms of quality of life. And what we see is that here is a DLQI 0 or 1 response through week 24. Again, similarly, we see a much higher response for patients that were randomized to the deucravacitinib group compared to the Prestillous group, and then compared to the placebo group. So what we've shown so far is the efficacy of deucravacitinib, not only through the primary endpoints of PASI 75, as well as clear or almost clear, but we also see the sustainability with a number of secondary endpoints of this response, and in more difficult to treat areas such as the scalp, and in the improvement in the quality of life. And now let's talk about deucravacitinib safety that was seen in the phase 3 trials. So what was shown is that overall deucravacitinib is well tolerated compared to placebo. In fact, when we look at nausea and diarrhea, which are oftentimes common AEs or adverse events with oral medications, what we see in the deucravacitinib studies is that the rates of nausea and diarrhea are similar to, or even a little bit lower than the placebo group. And I think this also resonates with the observation that the retention in the clinical trials, in the deucravacitinib trials, are also very good. And then when we look at overall other AEs of interest that are frequently discussed with JAK inhibitors, one did not see increased rates of non-melanoma skin cancers, malignancies, or serious infections. The rates of herpes zoster was increased in the deucravacitinib group compared to the placebo and the Prestillous. However, no cases of zoster with deucravacitinib were systemic, and none led to discontinuation. There were 2 cases of VTEs with deucravacitinib group. One occurred in the patient who had a IV placed in the arm, so it occurred in that IV line, and the other in the patient who had an aortic dissection that was complicated by a PE. Of note, that patient who had the PE later actually has survived all this, and then restarted on deucravacitinib, and is still in the trial. And there's also no increased rates of major adverse cardiovascular events seen in the trials with deucravacitinib. Here is the laboratory workup results for deucravacitinib. And what we see here is comparison of deucravacitinib versus a Prestillous versus placebo. And I would challenge you that if you didn't look at the legend on the bottom, you probably wouldn't be able to tell which one is which. Overall, we did not see an increase in the laboratory values with regards to cholesterol, creatine phosphokinase, neutrophils, platelets, and a number of other labs that are not shown here. So in addition to psoriasis data, which I talked about earlier, deucravacitinib is affecting also pathways that can be explored for other therapeutic uses. And this include psoriatic arthritis, ulcerative colitis, Crohn's disease, and lupus. And we'll just very briefly talk about psoriatic arthritis here. If you focus on the left-hand side of the slide, here is the efficacy of deucravacitinib in the joints for psoriatic arthritis. And what we see here are ACR 20, 50, and 70. And specifically for ACR 20, one saw that by week 16, so this is a week 16 response, that 62% versus 31% of the patients had achieved ACR 20 in the deucravacitinib versus a placebo group with the 2 different doses of deucravacitinib. And then we are now pivoting to another TYK2 inhibitor. This is brepocitinib. Brepocitinib was studied in patients with plaque psoriasis, the oral form, and here are the results from a phase 2A study. In this particular study, they looked at 2 different doses of brepocitinib, and it was found to have efficacy in patients with plaque psoriasis, and the efficacy was evaluated up to week 12. However, at the current time, the development of this oral brepocitinib program has been discontinued, and phase 2 trials are ongoing to look at potentially topical use of brepocitinib in mild to moderate psoriasis. And then for the PF06826647, currently a phase 2 trial is being completed, and hopefully we will see those results soon. And this is an area really ripe with a number of different developments for TYK2. And I think mainly due to the TYK2 and its pairing and their role in a number of autoimmune diseases. And what we see here, as you can see, are molecules that are in earlier development for psoriasis and as well as a number of other immune-mediated diseases. So in conclusion, you have heard from Dr. Gordon's really engaging talk looking at the psoriasis epidemiology, pathogenesis, as well as clinical burden, which really set the foundation and our understanding regarding the landscape and the rationale for therapies for our patients with psoriasis. And in addition to that, he also talked to us about the significant unmet need and how that remains in search for efficacious and safe oral alternative for patients with psoriasis. And then I spoke about the TYK2 and then the role of TYK2 in terms of its signaling and its role in mediating signaling of some of the key cytokines that are involved in psoriasis pathogenesis, including IL-23, IL-12, and type 1 interferons, and how targeting TYK2 can have beneficial effects in terms of decreasing psoriasis severity. And with that, I want to thank you for your attention for the talks that Dr. Ken Gordon and myself have just given looking at the role of TYK2 inhibition. And now we're going to transition to the workshop part where I will have a dialogue with Dr. Gordon regarding our perspectives on where and how selective TYK2 inhibition may fit into our existing psoriasis treatment paradigm. And just to start off our discussion here, I know Dr. Gordon is well aware that there are a number of limitations with existing therapies, and he talked about this in his portion of the talk as well. With topicals, while they can be helpful, oftentimes their use are quite limited in patients with moderate to severe psoriasis due to the large extent of body surface area. Our current oral therapies, there may be a consideration, a trade-off between safety and efficacy, and there doesn't seem to be a sweet spot where all of the oral therapies may be landing. And then finally, for the biologics, they have certainly transformed how we care for our patients with psoriasis, especially moderate to severe psoriasis. But as we know, biologics as a whole injectable class of medications are not for everyone. Number one, due to its route of delivery, and number two, due to a few other considerations that are related to the administration. So with that, I thought I would ask Dr. Gordon to start off with regarding the role of TYK2 inhibition and what he thinks. Dr. Gordon, what do you think about, and how do you think about TYK2 inhibitors, and how will they be positioned in the treatment of moderate to severe psoriasis in the context of the current treatment algorithms?
So I think the first and most important thing we need to consider is that last slide where you showed how few people are actually on systemic therapy for psoriasis that might benefit. And not only for their quality of life, but we talked about comorbid disease and people having greater than 10% body surface area. Many of those patients are not on treatment systemic therapy for psoriasis. And I think it's critical for us to remember that that's having an impact on their overall health, not only for their emotional health and on their skin disease. But that's the first real question. I think the International Psoriasis Council did a good job thinking about people who are candidates for systemic therapy. Once the decision to pursue systemic therapy has been made, which I think is being made too infrequently in our treatment algorithms today, I think we have to then differentiate between oral and biologic therapy. And much of that comes to patient preference. I think from a safety perspective, TYK2 inhibition, specifically very specific TYK2 inhibition that doesn't affect other JAK binding sites. If you just look at those numbers on safety, he had an extremely quiet safety profile. And I think that's critically important because that's really the issue that make biologics wonderful alternatives along with efficacy. So what you have is for the first time a small molecule that has a safety protocol that looks similar to what we see with biologics and very high efficacy. So when I think about it in terms of biologics, I don't want to compare one or the other. I think in terms of oral medications, which many patients find to be preferable, it really has to have the greatest sort of profile that we see to date in oral medications.
Great. Well, Dr. Gordon, I think you really hit a lot of the key points here. I completely agree with you that it still astounds me how many patients with moderate to severe psoriasis are not on systemic therapy when we know this day and age that it can help them to a very large extent and improve their quality of life. So I think more educational effort just on who may be appropriate to be on systemic therapy is important. And I think IPC really led the way in terms of redefining psoriasis severity as those qualifying or should be considered for systemic therapy, not only just based on body surface area, but also based on failure for topical therapy and also treatment of difficult areas. Regarding how do we identify patients who would likely derive benefit with treatment with an inhibitor of tyrosine kinase 2 pathway. And I think you touched upon that very eloquently regarding we need to really take into patient preferences, talk to them, because many patients, we can engage them in a meaningful way with regards to their preferences for the route of administration. And when we look at the safety profile for deucravacitinib, and especially the laboratory parameters that was shown, that what we noted was that it's essentially indistinguishable from placebo and from apremilast based on the phase 3 study. So we know that it has a good safety profile and it's very well tolerated. And therefore our conversation with regards to oral therapies now with deucravacitinib, once it becomes available, will likely to be quite different from the oral therapies that we have had with previously approved or previous other agents that we have in psoriasis. And I just wanted to hear from you if you have any other thoughts on this question.
Well, I agree with you entirely. I just like to have my own little spin on this kind of question because I hear this a lot. It's like, who would be a candidate? And the answer to that is really anyone who is in my office, is has disease that's not amenable to therapy and has psoriasis. And that's who'd be a candidate. And once you get past the idea of who's a candidate, which is kind of, a question is pretty much everyone who has disease, then the question goes down to, as you mentioned, patient preferences and how we go about treating the condition based on what's driving patients to get the therapy and what are going to be the factors that are most important to that patient. It's one of those things where we have to actually talk to the patient in front of us when making these decisions and not just think about populations.
Assuming clinical availability, how should we select among the various inhibitors from the JAK family in this era of expanding number of agents with differing mechanisms of action and differing safety and efficacy profiles? Well, I think that when we look at JAK inhibitors, it seems to me, at least to me, the development recently has been really focused in TYK2, targeting TYK2 in the psoriatic diseases. And so perhaps for the clinician, the question in terms of differentiation will have implication as it relates to the treatment of psoriatic arthritis, because we have JAK inhibitors, for example, such as tofacitinib, that's approved for psoriatic arthritis, and now deucravacitinib likely will be used in the future once it's approved, as well as a number of other medications that are being studied for psoriatic arthritis. And I think a lot of it will depend on the safety. I think one differentiating factor is that when we're looking at the number of oral JAK inhibitors that are available, deucravacitinib stands out in that it's targeting TYK2 specifically, whereas the other medications that I mentioned in my talk earlier primarily target JAK1 and 3, and then the later ones that are being developed primarily targeting JAK1 for psoriatic arthritis. Any additional thoughts on this, Dr. Gordon?
Again, I agree completely that the psoriatic arthritis is going to be sort of the place where we have to make these decisions. I think in just pure plaque psoriasis without arthritis, to date, I think deucravacitinib is going to be the agent that we'll go to because it'll be the one we have approval for in the United States. I think in psoriatic arthritis, I think that the safety profile will drive many of our decisions. And again, not having cross-reactivity with multiple members of the JAK family will really help sort of the TYK2 specificity in becoming the primary aspect. Though I have to say, in some of the JAK1 inhibitors, some of the data has been relatively good and better than sort of the pan-JAK inhibitors. And in particular, as we see other agents become approved for psoriatic arthritis, they might leak into the pure psoriasis population as well. But I think it really is the biggest differentiator is going to be safety, and that's going to be what has the most specific profile amongst the JAKs that are combined.
Great. I completely agree with that as well. So if I were a patient living in the Milwaukee area with psoriasis, and I would be so lucky to see you, Dr. Gordon, can you tell me a little bit about your approach to educating patients about new therapeutic options and even potentially clinical trial enrollment?
It's funny because when I see patients and I start getting a chance to talk about sort of what's new, I get excited. And I have to say, I have to temper my own excitement because being an old guy, I've seen psoriasis therapy go from methotrexate and a few patients on cyclosporin to what we have today. And the fact that we can make such major improvements in people's lives has been just incredibly valuable, I think, for the patients and has been one of the truly exciting parts of my career. One of the things that I talk about and how I go through it is I really try to go class by class with patients of all the agents. I want the patients to have an understanding of all the different options out there, and then to go through the advantages and the disadvantages. Knowing that, for example, with clinical trials, sometimes we can give people things that we have a pretty good sense are going to be highly helpful for them, but might not be available yet. And so I always thought of clinical trials as obviously for the science and what we can understand about pathophysiology as well as clinical care, is really the critically important thing, but also as a way to allow patients to expand what their options are, to think that there might be something that can help them, or they might have failed almost everything else before. So I go through quite a bit of detail. I can tell you the residents at Medical College of Wisconsin can pretty much quote me line by line with my lecture on what I tell patients about all the different options. But it clearly is something where we've gotten to the point where we have such high level efficacy and actually tremendous safety when we compare it to, for example, cyclosporin, which was our agent that got most of the people clear, in the ancient days. Maybe before you were born, Dr. Armstrong, and that we have that excitement. It's hard to temper the excitement, but we have to give people an honest approach. But I think it really is critical that people understand, and as we get new oral agents to add on to the biologics, we'll just have a new class of way to give medicine that I think will be something that's really exciting for patients as well.
Well, I have to say your patients are very lucky to have you, and I could only imagine they must share your enthusiasm when you talk to them about these new therapies. If you can provide your expertise on biologics and psoriasis and vaccination, just very topical, very topical, not in terms of putting stuff on the skin, but very relevant topic for our time today. So if you can comment on that.
I actually think that COVID questions are probably about 80% of the questions I get from my patients these days. And I think they're extraordinarily appropriate. I think it's very reasonable. So I think the first thing we need to think about is psoriasis and COVID. And people with severe psoriasis, it's of some controversy whether people are having worse outcomes if they have severe chronic inflammatory disease or not, but there is that possibility. And so it is my opinion that, and treatment in no way has shown to increase risk associated with COVID. So it is my opinion that there is enough out there to even emphasize in the time of COVID, it's extremely important to get people with more severe forms of psoriasis treated, regardless of concerns about viral immunity, which most of our treatments don't impact all that much. In terms of COVID vaccine, we're talking about this, just a few days after we've had announcements on immunosuppression and a COVID vaccine booster. And I think that if you look at many of our treatments for psoriasis, including the biologics that affect the IL-17 pathway and the IL-23 pathway specifically, there's not a lot of reason to believe that they would be any more at risk for needing a booster than anyone else. So I wouldn't go out emergently to get boosters in those populations. I would actually think that way about anti-TNFs, though there's a little bit of data, particularly with infliximab, that there's some decreased response. And so my institution has defined anti-TNF patients as people who should get a booster of their vaccine. I think that in the context of anti-TNFs and methotrexate, I don't question that at all. Anti-TNFs by themselves, I could argue one way or another, but since my institution feels pretty strongly about it, I'm going to suggest to patients on anti-TNFs that they get the booster. But really, for all the patients who I treat, I am trying to emphasize the need to get vaccinated.
That's great, and thank you for that relevant discussion. I agree that booster recommendations, I feel like it's changing by the hour. So we will see how that evolves, not only for our patients, I think also for many of our listeners, healthcare professionals, with regards to how many months out, and that we will be getting our booster shot. So pustular psoriasis is definitely a topic that's difficult to approach and address because of our level of evidence for pustular psoriasis just so much lower than for plaque psoriasis. As we know, pustular psoriasis can be divided into more generalized pustular psoriasis versus localized. And when we're talking about the localized, I typically think about palmar-plantar pustulosis. So maybe I'll discuss that very briefly first. For palmar-plantar pustulosis, as we know, we don't have an FDA-approved medication to treat this particular subtype of psoriasis. However, based on clinical kind of experience as a field, we have had some successes, although efficacy being somewhat modest with either cyclosporin or acitretin when we're thinking about more traditional types of oral therapies. And then more recently, in terms of our biologics, I think the data is probably most abundant with IL-23 inhibitors, specifically guselkumab from some of the Asia data. So if you're able to get your hands on, for example, an IL-23 inhibitor for pustular psoriasis, I do think it's worth a try for the localized type. And for the generalized pustular psoriasis, I would say that we have really gained understanding as a field on some of the causes for generalized pustular psoriasis, at least in a good proportion of our patients. And it relates to the IL-36 RN, basically this natural inhibitor in our body that interacts with the IL-36 receptor. So there are a number of medications that are in development that targets IL-36 receptor. None of them are approved at the current time for GPP. So using the ones that we currently have available, I would say that probably cyclosporin is something more accessible to people, especially in an inpatient setting where patients need to be managed quickly. TNF inhibitors is an option, and I've tried that on a few patients in the past, and that has some success with that in a generalized GPP setting where they may be quite acutely sick and needing something to address that.
I would just like to add one thing to the discussion of the localized palmar-plantar disease. I think I agree with you on everything you said. It's been my experience that small molecules have been preferable over time in the palms and soles. There might be many reasons for that, but I'm really looking forward to the day we begin to see some of these new small molecules in really good studies of palmar-plantar disease, because I think that's one of the great needs that biologics don't always do as well as we'd like. Though there is data, as you mentioned, particularly with guselkumab and the anti-IL-23s. But I would be really excited to see more information on small molecules as a way to potentially go after and really treat these patients, because I think that in some time in the future will be the place to go.
Absolutely. And then, Dr. Gordon, how do we get psoriasis patients better quickly?
Yeah. So that's another one of my favorite topics. I have a running joke with one of our colleagues, Mark Lebwell, who works in New York City, and he talks about the need to get patients better fast, people who are actors and people who are politicians and leaders in business. And I always think that's a really big issue in Milwaukee. Maybe not so much as in LA or in New
I
York.
can relate to that in LA, but
Yeah.
yes.
Speed is an interesting question because I think patients want to get better faster. There's no question. And using numerous of our medications, and I mean, speed with methotrexate and speed with almost any of our biologics we use frequently are two fundamentally different things. So all of our medicines work quickly, and the relative speed of ixekizumab versus guselkumab might be important, but maybe not so significant when you look a year down the road. And we always have to remember that psoriasis is a disease that is a long-term disease, and that what happens over the first 4 weeks is important, but might not be that important a year, 2 years later. So I think we always have to think about what's really driving treatment. In those patients who need to get better faster, medications like cyclosporin have been traditionally used to get people better faster. But I really don't think it's any faster than most of our modern biologics that can act very quickly. I think with medicines like deucravacitinib, as we see going forward, we might have things that work quickly. But I think it's the predictability in combination with the speed that's important. Predictability is what's the likelihood of a patient getting better? And that's critically important along with how fast that patient's getting better.
Mhm. Absolutely. I think both the speed as well as ability to maintain that response are two important factors. And I'm going to apologize in advance, but unfortunately we have run out of time. And I want to thank all of you who have stayed with us for this program, and thank all of you who have submitted your questions. Again, my apologies if we haven't gotten to all of the questions. But we really appreciate your engagement and your time with us today. And before you go, please remember to complete and submit your post-test and evaluation for CME credit. And if you felt like you missed anything or wanted to go back over, you can go to peerview.com/psoriasis21. And there you can download the slides as well as a practice aid by clicking on the buttons located in the left-hand panel. And importantly, you can watch the replay of this event. So you can watch Dr. Gordon over and over for as many times as you want. And also please join the conversation on Twitter at PeerView. And thank you so much for your time, and have a great evening.